Hello everyone, welcome to my YouTube channel Dr. Akif Beg. Today we'll be talking about acute rheumatic fever and rheumatic heart disease. So we'll go to the definitions actually. So what is acute rheumatic fever? So it's an acute illness which is actually caused by an autoimmune response to infection with group A Streptococcus. So what happens is that whenever there is an infection with a group A Streptococcus, and our body will react to that group A Streptococcus because of its some particles which is immunogenic. It leads to an autoimmune reaction which leads to a various symptoms which is labeled as acute rheumatic fever. It may affect any or all of organs like heart, joints, brain, skin, and subcutaneous tissues. The next terminology is rheumatic carditis. So what is rheumatic carditis is that any inflammation of the heart. So if they are acute rheumatic fever or anything, any infection by the group A Streptococcus is affecting your heart directly, and most commonly it affects the valves, and in that also predominantly mitral valve and aortic valves. When it involves the valve, it is called as rheumatic carditis. And if this rheumatic carditis continues for longer time, it can lead to various valvular pathologies like mitral regurgitation or basically regurgitation or stenotic lesions. So if in acute settings, most commonly leads to regurgitation, and in chronic, as in a chronic infection keeps going, so that infection keeps getting deposited on the valve and leads to calcification, and that causes mitral stenosis or aortic stenosis. The persistent damage to the heart valves leads to either regurgitation, which is could be most commonly mitral or aortic regurgitation, or in a long-standing case may lead to stenosis. So there is a terminology which is important to know because the diagnosis criteria of rheumatic fever depends upon the low risk areas and the high risk areas. So what is mean by low risk area is that any area or any country or any place where the incidence of rheumatic fever in children of age group 5 to 14 years. So because the children of 5 to 14 years commonly get infected with acute rheumatic fever is mostly seen in this age group. So if the prevalence is less than 2 per 1 lakh per 1,000 year, then it is called as low risk. Or any prevalence of chronic rheumatic carditis of 1 or more, then in 1,000 it is called as that. So less than 1 in 1,000 of rheumatic carditis or less than 2 in 1 lakh per year of acute rheumatic fever is called as low risk. And high risk means by more than 2 per 1 lakh year and more than 1 per 1,000 years of chronic rheumatic carditis. So commonly countries which is found that India is actually comes under moderate to high risk populations, other countries being Australia, China, and Saudi Arabia, and various other countries as well. So what happens in a rheumatic fever is that there is a susceptible host, that is a humans who are susceptible host. One by one risk factors we'll be discussing in detail. So the susceptible host get infected with a group A Streptococcus infection. So on repeated group A Streptococcus infection, what happens is that first it leads to initial priming of the immune response. That initially there's an exposure which triggers their immunity, and on repeated infection, the immunity gets hyperreactive and leads to autoimmune illness, which presented later as rheumatic heart disease. So what are the risk factors? Is that the most common risk factors which we discuss is the age, and it's commonly seen in the acute rheumatic fever. Is normally seen in the age group of 5 to 14 years, and it is very rare to see. It can be seen later, but it is very rare to be seen after 30 years of age. Or recurrent episodes, if there is recurrent episodes can be seen that also, but maximum age of recurrent episode is also below 35 to 40 years. So you cannot label any patient as having acute rheumatic fever if symptoms are occurring after 30 years of age. Then you should suspect some other illnesses. So acute rheumatic fever normally presents at 5 to 14 years of age. Then it's rheumatic fever which may prolong and cause rheumatic heart disease, which is commonly manifest at the age of 25 to 45. So normally they say it starts in the third decade of your life. Rheumatic heart disease usually manifests at third decade, whereas acute rheumatic fever is commonly seen in age group of 5 to 14 years. So acute rheumatic fever, which is the initial infection with the group A Streptococcus, is seen equally in males and females, whereas rheumatic heart disease is more common in females when compared to males. So why is so? There has been various reasons which has been explained that why females are more predominantly known to get rheumatic heart disease is that there is, as we all know, autoimmune illnesses as per genetic wise is more common in females. So that could be one of the reason why females are getting more rheumatic heart disease. Second is that because the females tend to take treatment very late, because in the villages and all, women are not given that much preference, or their health is not considered as primary at many places still now also. So what happens is that because they do not take treatment at the right time, obviously the chances are that that group streptococcus stays inside the throat for longer time and may affect the heart. And that's why rheumatic heart disease are more common in women's. Maybe one of the explanation has been given. And another explanation has been given that as women are there, most of the time, women spend most of the time with their kids or child, and because the children are known to commonly known to get these infections of group A streptococcus, there are greater exposure of when compared to men, there are more exposure of females to those infections. So that's why there is more chances of recurrent infection, more chances of rheumatic heart disease as well. So these are the three explanations which has been given why rheumatic heart disease is commonly seen in females rather than men. Next is environmental factors. It is that this is a disease of poor people, and it is seen in overcrowded areas, and that's why, as you all commonly know, there is a social injustice, and which is also being seen in this disease as well. Organism-wise, as we already discussed, this is caused by group A Streptococci. Previously, they used to say classically M serotypes of group A Streptococci, but now they are thought as that any strain of group A Streptococci can actually lead to rheumatic fever. And host factor-wise, some association has been seen with genetics. What they have seen is if monozygotic twins, if one child has, the other child is also known to get this in 44% cases, whereas in dizygotic twins it is 12%. Immune response. The most common explanation been given, we all been reading since our MBBS time, is that is because of the molecular mimicry. What happens is that there are some particles of group A Streptococcus which resembles to that of our normal organ structure. So what happens is that our body, whenever there is an infection, our body tries to go and attack that infection, and it gets confused because some of the particles of that infection is similar to the other particles which are there in our joints, heart, and all. The immunity gets confused that it is also a foreign particle, so it starts attacking other organs, that is heart, skin, and your brain and all. That is confused with basically M protein. It starts attacking the other parts, and that's why the manifestation starts. One more hypothesis what they have been given is that the M protein of the group A streptococci, it goes and binds to the type 4 collagen in the structures epithelium. So which when this M protein goes attached to the type 4 collagen, it makes them immunogenic. So immunological reaction goes and attacks that part. That is one of the other explanation has been given. So this is the basic risk factors and all we have discussed. Now we'll go to the clinical features. So what is that? Once if any patient has been exposed to a group A streptococcus, there is a latent period which is around 3 weeks. So it is time period between the group A streptococcus infection and appearance of clinical features. And generally all the other features of rheumatic carditis, that is most common is fever, or it may be joint pains. Joint pains is all comes very earlier, whereas the exception to them is that chorea, that is Sydenham's chorea, and carditis appears late. So it is a late manifestation, and almost a little bit has been seen up to 6 months. As we already said, the other manifestation, basic manifestations we see is normally 3 weeks, but carditis and chorea is a delayed manifestation which is seen after 6 months of acute group A streptococcal infection. The most common clinical features in rheumatic fever is the polyarthritis, which is seen in around 60 to 75% of cases. And second most common is carditis. And prevalence of chorea, erythema marginatum, and subsequent nodules has been very less, that is around less than 5% of cases. Let's talk about heart involvement. It is seen in around 50 to 60% of patients with so all around, if acute rheumatic fever is there, so around 60% of patients will progress to rheumatic heart disease if they do not receive the treatment properly, or there is no prophylactic treatment if started. It affects all the 3 layers of the heart, that is endocardium, pericardium, and myocardium. And what is the hallmark of rheumatic carditis is that valvular damage. Amount of valve, basically in the heart, the valves are getting damaged most of the time. So, and that most commonly it is mitral valve is affected most commonly, followed by the aortic valve, and very rarely it affects the pulmonary tricuspid valve. Usually, the involvement of pulmonary tricuspid valve is seen secondary to this mitral valve illnesses, but as such, isolated pulmonary tricuspid valve involvement is very, very, very rare. You can see the prevalence wise isolated MS, that is mitral stenosis, is 25%. So most common presentation is combined mitral stenosis and mitral regurgitation, which is seen in around 40% of cases. Mitral stenosis plus aortic valve involvement has been seen in 35% of patients, and mitral stenosis plus tricuspid valve involvement is very rare, that is 6% of cases. So if there is alveolar early valvular damage, so as soon as this it is damaging the valve earlier, at that time it will not let the two valves to get opposed properly and leads to mitral regurgitation. So as and when disease progress, what happens is there is leaflet thickening of the leaflet of the valve, which is scarring, calcification. All these things leads to narrowing of the space leading to valvular stenosis. Also, there is that this inflammation and all attacks the nodes, AV nodes and all, which will lead to PR interval prolongation. If your AV node is affected, so there is different decrease in conduction from SA node, there is sinoatrial node to atrioventricular node. So and from so atrioventricular node conduction is detected in ECG by PR interval. So that's why there is PR interval prolongation has been seen. So joint involvement, if you talk about, most commonly it is seen in around, it is the most common manifestation of acute rheumatic fever, seen in 70% of patient. And traditionally it is called as migratory type of pain. What do you mean by that? Is that initially one joint is involved, which is when then it subsides, followed by the other joint starts getting involvement. And in some cases, very rarely, there could be additive effect rather than migratory, with simultaneous involvement of several joints. The joint may be inflamed. So affected joint may be inflamed for only a few days. That is what is called as migratory type of joint. So few days it is affected, then it resolves, followed by the other joints. And most commonly it affects the large joints, and this lower limb is more common. There is asymmetric involvement. That is not uniform involvement of the joint. There is asymmetric involvement. One joint maybe get more worsened than compared to the other joint. So this asymmetric usually affects the lower limb, and it usually stays for a few days to 1 week. If suppose you have seen any joint swelling which has been persisted for more than 4 weeks, you should suspect some other illnesses and evaluate for that. So, and also monoarthritis, single joint inflammation has been observed in around 17 to 25% of patients, and large joints are most commonly involved. Next is Jaccoud's arthritis. So Jaccoud arthritis is a special type of arthritis which is seen very rare. It is one of the manifestations of chronic post-rheumatic fever arthropathy, and usually affect the small joints. Normally, rheumatic fever, if there is arthralgia, it affects the large joint, it affects the small joint. So Jaccoud arthritis affects the small joints. There is fingers involvement most commonly, which leads to swan neck deformity, which is called as hyperextension of the metacarpophalangeal joint and reflection of the metacarpophalangeal joint and hyperextension of the proximal interphalangeal joint. That is what is commonly seen in this case. Chorea. Sydenham's chorea is one of the classical manifestations of rheumatic fever. Most commonly, it affects the head and the SY head, and it causes choreiform movements of the head. It may be generalized in various patients, and it is a delayed presentation. It is not manifested initially after the group Streptococcus. Usually manifests around 6 months after the infection with group Streptococcus, and it lasts for around 6 weeks to 6 months. Erythema marginatum is one of the other major manifestations which is seen in rheumatic fever, where there is a formation of macules. There is a pink macule forms, and it starts clearing, like that clears centrally. So it has formed the molecule to start getting clearly. Centrally it starts getting clear, so that there is a gap which is formed there. It's called erythema marginatum. All the erythema is seen only in the margins, and the rash is evanescent. What does you mean that? When you keep seeing on the patient, if you keep seeing this rash, it appears and it disappears in front of the examiner eyes. And mostly all this rash is seen over the trunk, and it is not commonly present around the limbs. Subcutaneous nodules is the other thing which is another major manifestation of rheumatic fever. Is commonly seen is in the bony prominences, is hand, feet, elbows, and occiput. Is the back of the head, but they're all painless nodules. and this is also one of the delayed manifestation, and commonly it is seen associated with carditis. You can see prominence of this nodules here at the great toe and near the elbow and near the bony prominences, you can see here. Fever also occurs in most of the cases, but it may be absent in case of pure chorea. Although high-grade fever is the rule, sometimes even the lower-grade temperatures are not very uncommon. And you will see elevated acute phase reactions like ESR and C-reactive protein. So this is the clinical manifestation. Let's go to the diagnosis part. So initially, the diagnostic criteria was Jones criteria, which included major criteria and minor criteria. Now it has been modified based on the low risk and high risk endemic areas. So what was this issue say before is that for diagnosis of rheumatic fever, there should be an evidence of streptococcal infection. You should have an evidence of group A streptococcal pharyngitis, which is proven by either you take a throat swab culture should be there, or you take a rapid streptococcal antigen test, like rapid streptococcal antigen test, or you do is rising streptococcal antibody titers. Like you measure the antibodies to streptococcal antigen, that is called ASO titers, and after 2 weeks you repeat again. If there is sequential increase in ASO titer, that means it is an acute rheumatic fever. And also along with that, there should be two major or one major with two minor criteria. Major criteria included polyarthritis, as we have already discussed, carditis, that is heart involvement, chorea, erythema marginatum, and subcutaneous nodules. Minor criteria include fever, arthralgia, that is joint pain without inflammation, prolonged PR interval, as we have already explained, and elevated ESR and CRP. This has been modified in the modified Jones criteria. That is, first there should be all should have evidence of preceding group A streptococcal infection with either with throat culture or with you do with rapid streptococcal antigen test or serological with antibodies. So there should be two major manifestation, or either one major with two minor manifestation. So it has been modified as either low risk population, which is less than 2 per 1 lakh per year population, is low risk population, and moderate and high risk population. So initially carditis was said to be clinical. Here they have included even the subclinical carditis. That is, the patient may not have any clinical manifestation of carditis, but on echocardiographing you are seeing a carditis changes. And initially they used to say there should be only polyarthritis should be there in major criteria. Now in high risk population they have even included polyarthritis, that is without inflammation also, if there is multiple joint pain is there, or monoarthritis, there is inflammation of single joint. This is also included in the major criteria. And minor criteria, there is a small difference in low risk versus moderate and high risk. That is, fever of more than 38 is sufficient in moderate and high risk, whereas low risk should be more than 38.5. ESR should be more than 60 in the first hour in low risk population, and more than 30 in the high risk population. So evidence of preceding group A streptococcal infection should definitely be present, because and it is very rare to find a positive throat swab culture rapid antigen test. Usually, most commonly we use serological test, which is anti-streptococcus O and anti-DNS-B titers. Anti-streptococcus O titer usually rise approximately 1 week after the infection, and it peaks around 3 to 6 weeks after the infection. And similarly, anti-DNS-B titers begins rise 1 to 2 weeks, and it peaks around 6 to 8 weeks after the infection. So how do you treat rheumatic fever? Is your main aim is to suppress the inflammatory response, and so if you suppress the inflammation, there are less chances of damage to the other organs as well. You should eradicate the group A streptococcus from the pharynx, because if the streptococcus stays there, it will be immunogenic, like it will be keep triggering your immunity to hyperreact. So you have to eradicate it from the pharynx, and you should give symptomatic relief because the patient is having symptoms, and to commence secondary prophylaxis so that you can prevent the patient from progressing into rheumatic heart disease. So if a patient has unconfirmed diagnosis presenting with monoarthritis, so suppose patient has only monoarthritis, that is inflammation of a joint with pain, but the diagnosis is not confirmed, you should actually give only a normal like paracetamol or simple analgesics. NSAIDs should not be started, because NSAIDs will lead to misdiagnosis. So NSAIDs should not be started till the diagnosis is confirmed. Once there is acute rheumatic fever is confirmed, you should give treatment with an antibiotic to eradicate the group A streptococcus. Most commonly used is penicillin. So this rheumatic fever, this penicillin has no effect in whatever the acute rheumatic valvular lesions of the heart. So rheumatic valvular lesions, it will not get cured with that, but it will definitely it will remove the penicillins will remove that group streptococcus from the throat, and thus this will prevent the formation of rheumatic heart disease. So what we commonly use is oral phenoxymethylpenicillin, that is penicillin B, which should give for 10 days, or you can give a single injection of benzathine benzyl penicillin. Antibiotics, what you can use is most commonly is penicillin is a drug of choice. You can either use benzathine penicillin, that is 1.2 million units, if your weight is more than 27 kgs. If your weight is less than 27 kgs, 6 lakh units is sufficient, single dose is sufficient. Or you use amoxicillin or penicillin B. These both are given for 10 days. If there is carditis, most patient with mild or moderate carditis, if there is no heart failure, if only there is valve normal but there is no heart failure, it doesn't require any therapy because it is seen that most of the time subsides on its own with bed rest. Okay, and if there is symptoms of heart failure, it is treated like normal treatment of heart failure as well. So despite despite the absence of there is high quality evidence is not there to support glucocorticoids, and its role is very much controversial. Few studies have shown benefit, few studies have not shown much benefit. So its role is still not recommended in patients with carditis yet. Bed rest is the most important treatment because it also decreases the joint inflammation, as well as it will prevent the patient of carditis to progress to heart failure as well. Salicylates and NSAIDs are the mainstay of treatment in case of arthritis and arthritis and fever. So all this gets subsided. You can start most common drug which is used is aspirin. They are of no proven role in the treatment of carditis. In carditis and in children and chorea, there is no role of this salicylates and NSAIDs. Aspirin also, it is not the routine use what we use for the cardiac diseases like coronary artery disease. You have to use it at a very higher dose, at around 50 to 60 milligrams per kg per day. Chorea is usually managed with carbamazepine or sodium valproate, which is a drug of choice. If milder cases can usually be managed by providing a calm environment. So response may take time because it may not act very fast. So medication should be continued for at least 1 to 2 weeks after symptoms subside. So effect of these medicines are usually seen 1 to 2 weeks after you start the treatment, and it has to be continued even after that 1 to 2 weeks after the symptoms are subsided. Prognosis, if you don't treat it, if you keep this untreated, normally acute rheumatic fever lasts for around 12 weeks. The symptoms may present till 12 weeks. If you do treatment with antibiotics and all and such, the treatment is actually shortened to 1 to 2 weeks. So how do you monitor your treatment? Is it after you start like salicylates or NSAIDs and all, you have to keep monitoring the inflammatory markers. The inflammatory markers should come to normal. And also, once the patient is recovered from acute rheumatic fever, after a month, you should definitely ask all the patient to undergo echocardiogram so that to know if there is a progression of rheumatic carditis or rheumatic heart disease is there or not. So there is two prophylaxis which is important to know: primary and secondary prophylaxis. Primary prophylaxis is that which will prevent the occurrence of rheumatic heart fever. For example, if you have got sore throat in the childhood or you get fever with sore throat, you should start treatment within 9 days of exposure. If you start the treatment within 9 days of exposure, it will be complete eradication of the group A Streptococcus, and it will not lead to formation of acute rheumatic fever. As we all know, it's around 3 weeks of latent period is there. Within 9 days, if you start the treatment, the group A Streptococcus is gone, and so it will never progress into acute rheumatic fever. So this is preventing that disease. So that's why it is called as primary prophylaxis. So the various drugs which we have already discussed is penicillin B, amoxicillin, and benzathine penicillin. Other drugs which you can use is clindamycin, azithromycin, and clarithromycin. Acute rheumatic fever can recur as a result of subsequent group A Streptococcus infections. So each recurrence can actually increases the chances of rheumatic heart disease. So that's why you need to give secondary prophylaxis. If the patient has got rheumatic heart fever, there is rheumatic fever, acute rheumatic fever without heart involvement also, there are high chances that it may progress to rheumatic heart disease. If there is rheumatic heart disease, the patient is already developed rheumatic heart disease, then also you should give a secondary prophylaxis, but it prevents the worsening of the rheumatic heart disease. Secondary prophylaxis is the best antibiotic which uses benzathine penicillin G, which is given at a dose of 1.2 million units. If your weight is more than 27, if your weight is less than 27, you use 6 lakh units. It should be delivered every 3 to 4 weeks. Other drugs you can use is oral penicillin B, 250 milligrams twice daily, but it is less effective than compared to penicillin G. If anybody has penicillin allergy, you should give erythromycin 250 mg twice daily. Base drug which you can use for secondary prophylaxis is benzathine penicillin G. If there is allergy to penicillin, then you use macrolide, or you can use erythromycin. That is erythromycin 250 mg twice daily. So American Heart Association recommendations for how long you should give secondary prophylaxis is that if there is rheumatic fever, if you have developed rheumatic fever and there is no carditis, there is no cardiac involvement as such, you should give for a minimum of 5 years, or till the child gets the age of 21 years, whichever is longer. Whichever is longer, you should do it. At the total duration of 5 years, or till the patient gets age of 21, they should be given. If there is rheumatic fever with carditis, that is heart involvement, but there is no residual valvular disease. Like that means the valves is involved, but there is no mitral stenosis, mitral regurgitation, and all this has not formed. There is no regurgitation stenosis, but only carditis is there. Then you should give a minimum of 10 years, or till patient approaches 21 years of age. Whichever is longer, that should be chosen. If your patient has a persistent valvular disease with symptoms of features of stenosis or rheumatic heart disease, that is stenosis or regurgitation, then you should give either for 10 years or for 40 years of age. The patient achieves 40 years of age, whichever is longer, that has to be preferred. That is AHA recommended. WHO has different goals. WHO says if a patient have no proven carditis, you should give her for 5 years after the last attack, or till 18 years of age, whichever is longer. WHO. And if there is carditis with only mild mitral regurgitation, then you should give at least for 10 years, or till the patients achieve the age of 25 years. If there is more severe valvular disease with moderate mitral regurgitation, mitral stenosis, it should be given lifelong. And after valve surgery also, they said that there are chances of progression is still there, so you should give it lifelong even after that. So again, AHA recommendations and WHO criteria. So different people follow different guidelines, so it all depends upon which guidelines you like to follow. And hope you have liked my video. If you have any doubt in this topic, do let me know, and you can comment in my comment box. If you like my video, do subscribe to my YouTube channel, Dr. Akif Beg, for more interesting videos. Thank you.